Good morning, everyone. Thanks for coming out early this morning. I'm Brandon Chase, and this is Deb Kelly, and we were the two members of the Clinical Sciences stream for the Scientific Committee, and I'm going to pass it over to Deb now to introduce our speaker.
So we're absolutely delighted to introduce our next speaker, and for those of you who have been at CAHR before, I feel like he actually doesn't need an introduction. However, I will. So Dr. Darrell Tan is a physician and clinician scientist with St. Michael's Hospital, and he's an associate professor with the Department of Medicine and the Institute of Health Policy Management and Evaluation at the University of Toronto. Dr. Tan is an infectious diseases, he's also, repetition here. He also holds a cross appointment with the Institute of Medical Science, and his research focuses on clinical trials and implementation science in the areas of HIV prevention, HIV treatment, and sexually transmitted infections, including Mpox. Dr. Tan also holds a Tier 2 Canada Research Chair in biomedical HIV and STI prevention. He's the co-lead for the Prevention and Testing Think Tank of the CAHR Pan-Canadian Network for HIV and STBBI Clinical Trials Research, and is a member of the Governing Council of the International AIDS Society. So please join me in welcoming Dr. Tan as he talks to us about the promise of PrEP.
Good morning, everyone. Thank you so much, Brandon and Debbie, for this huge honor of being here today. It's really something that has humbled me to be invited to speak to you today. Bonjour tout le monde, c'est vraiment un grand plaisir d'être ici devant vous pour parler un petit peu de la promesse de la PrEP. Je vais faire la présentation en anglais, mais si vous avez des questions en français à la fin, ce serait un plaisir d'y répondre. Before we go any further, I also want to just acknowledge that it's also a privilege to be here on the traditional territory of the Mi'kmaq people, and point out the great irony of doing a talk about the promise of PrEP in that context, because I think, as you'll see through the next half hour or so, one of the big themes of what I'd like to talk about is how I think we're failing on the promise of PrEP. And nowhere is that more true than for Indigenous people across this country. We know in particular that since the beginning of PrEP, really, in this country, it has actually been available. TDF-FTC, tenofovir disoproxil fumarate with M-tricytamine, has actually been fully funded under the FNIB, which is a racist piece of legislation, but nevertheless one through which First Nations and Inuit people could have accessed free PrEP from the outset, but we failed on that promise. So, the last thing I have to say is I have a very important announcement, which is that we will soon be accepting nominations for the CAHR 2025 Award for the Most Beautiful Title Slide, and I hope that I have your vote. So these are my conflicts of interest. There are some, they are restricted to research initiatives that have been investigator-initiated, as well as some participation in industry-sponsored clinical research as well. So what I hope to talk to you a little bit about today is to review some of the clinical data, just briefly summarizing the safety and efficacy of various PrEP formulations. I'm not going to go into a lot of detail on the specifics of study methodologies and findings, but rather just highlight some high-level messages. I'll also do that for some of the challenges to the more effective rollout of PrEP in Canada, and hint at some strategies for overcoming them, which I think really rest on us reconceiving how we think about PrEP, not as just a clinical intervention, which is how I think we've approached it to date, but rather as a public health intervention. Even though I know that this is the clinical sciences plenary, I do think we have to think of it in that way and do so in a way that emphasizes the power of choice if we're going to succeed better than we have. So to start on reviewing some of the products that we have available. So we all know that TDF-FTC has been demonstrated to have great efficacy as a PrEP product for over a decade and a half now. And you can see on this slide here a number of seminal clinical trials comparing it to placebo, demonstrating that this product is efficacious, whether we're talking about gay, bisexual, and other men who have sex with men, or transgender women, or heterosexual men and women, or people who inject drugs. And that's been demonstrated in study after study around the world. Sometimes folks who don't know our field that well look at the numbers in the right-hand column. Those are the point estimates for efficacy from the initial seminal trials and say, you know, that doesn't look all that impressive to me when a condom is like 94, 95% effective if used correctly at preventing HIV. And while that's a fair statement to make, we know that adherence with the study drugs in these trials was not great and is not reflective of real life, because the participants in those trials were, of course, told, we don't know whether this works. There's a 50% chance that what I'm giving you is a placebo. The motivation to use the product was not as high as it should be today. So we see this beautiful relationship between adherence and efficacy when we look across studies. Each dot on this graphic is a different study. The x-axis is a proportion of folks who had detectable drug levels. The y-axis is the point estimate for efficacy from the various trials. There's a very clear linear relationship at the study level and also at the individual person level. So here are some data from gay, bi, and other men of sex with men who are all trying to take their daily oral TDF-FTC daily, but perhaps only succeeding in doing so, 4 to 6 days per week, 2 to 3 days per week, or whatever. At the bottom, you can see that mapped onto drug concentrations, tenofovir diphosphate levels in their dried blood spots, and this is plotted against HIV incidence. And we see that even folks who are trying unsuccessfully to take their pills every day and end up taking it only 4 to 6 days per week, end up with a point estimate of efficacy and risk reduction of 100%, albeit with a confidence interval around that. This has also recently been demonstrated to be true, more or less, in cisgender women. And throughout my talk, I'd like to highlight the great work of Canadian scientists who have been working in this field. Marissa Becker co-led this work with Jeannie Marazzo, showing that in women who had consistently high adherence with their PrEP, so that's defined again as 4 to 6 tablets of daily TDF-FTC per week, looking across multiple studies, the incidence of HIV is actually extremely low, and we see the same gradient as we saw in GBN, more or less, in terms of adherence and efficacy. Now, not everyone needs or wants to take a pill every day, of course, and so led by our colleagues in France from the INRS, as well as under the leadership here in Canada of Cécile Tremblay, the IPERGAY trial showed us that you could also use PrEP in an on-demand fashion. So taking 2 pills of TDF-FTC within 2 to 24 hours before sex, followed by 2 daily pills thereafter in GBM, has been demonstrated to have tremendous efficacy as well. 86% compared to a placebo, and the only reason that that isn't closer to 100% is that there were 2 individuals in this trial in the active arm who unfortunately seroconverted, but told the study staff at that point, I was not using the study intervention. A number of cohort studies around the world, Hong Kong, China, France, and elsewhere, have since looked at the real-world effectiveness of this regimen and effectively shown that it is not different. We meta-analyzed those results here from daily oral TDF, and I think this is a regimen that we really underuse in this country, in most parts of the country at least, and need to be doing better with. Now, there is another product that can also be used on a daily basis. That's tenofovir alafenamide with FTC. It's been studied in GBM, gay, bi, and other men of sex with men. There was also some participation of transgender women in this study, about 2% only, not a large number at all, but there was some participation, and it was shown to be non-inferior to daily oral TDF-FTC, which is great. The advantage of this product, of course, is that it has a better renal and bone health profile. You can see in the right-hand side here, the blue line is the TAF-FTC. Folks tended to have a lower creatinine over time. They therefore had a higher creatinine clearance over time, and they did not see the modest drops that we do see in bone density at the hip and spine that we see with TDF-FTC. Now, the big challenge with this product, however, is that it is not really available, right? Pricing is a big issue. We're going to come back to that in a minute, and this is not publicly reimbursed as a PrEP option across the country. A product that we don't talk about very much at all here in Canada, of course, because it's not available and it's not destined to become available, is the dapivirine vaginal ring. So this is a silicone ring that can be inserted into the vagina every month and changed on a monthly basis, and it slowly elutes this non-nucleoside reverse transcriptase inhibitor dapivirine right at the site in the body where it can hopefully take effect. And that's exciting because it can be used without the knowledge or consent of a male partner, empowering people with a vagina, typically these were cisgender women in sub-Saharan Africa, to protect themselves. Now, the point estimates for efficacy from these trials were not that impressive, as you can see on the slide. It was likely underdosed in the product, and the next generation will look at this at a higher dosage. But when there were analyses done of women who were more adherent to the product, it did rise somewhat to the 50 to 60% efficacy range. Nevertheless, it is a product that exists out there as a topical formulation of PrEP and should be considered when we talk about PrEP. Perhaps a little more relevant to our context and really, really exciting is the fact that we now have in this country available to many people 2 monthly injectable long-acting cabotegravir as PrEP, which, as you all know, was demonstrated in the HPTN 083 and 084 trials, which were done in GBM and transgender women, as well as cisgender women in sub-Saharan Africa, respectively, to be not only non-inferior, but actually superior to daily oral TDF-FTC as a PrEP option. And this is super, super exciting. How can you possibly do better than a product that we've already said can almost be 100% effective when you take it regularly, which is the oral PrEP option? Well, it's clearly because a long-acting injectable can overcome the challenges that many, many people are going to have with trying to take a pill every day. We've learned this through the treatment experience as well. We know that there are privacy concerns. We know that there are safety concerns sometimes for people if they don't have the privacy to use products. We know that there are stigma and self-stigma related concerns that inhibit people from taking a daily tablet, and this can overcome this. And it's exciting news to know that this is now reimbursed in Quebec, in Ontario, under NIHB, and hopefully that trend will continue. And looking to the near future, we hope to soon have not 2 monthly, but 6 monthly injectable PrEP in the form of lenacapavir. I'm sure you all know about the groundbreaking results of the Purpose 1 and Purpose 2 trials, which are shown here, demonstrating that in young cisgender women on the left, as well as GBM and the most diverse group of gender diverse people, so about 25% transgender men, transgender women, and other gender diverse people in Purpose 2, showing that this product, once again, was not only non-inferior, but actually seemed to be superior to the daily oral comparators, and certainly compared to the background estimated HIV incidence, which is what we see in blue. So stay tuned for this product coming soon. So, with all these options, boy, should we be doing well at preventing HIV in this country, right? Unfortunately, that's clearly not happening. So these are estimated HIV incidence data for Canada over the lifespan of the epidemic. And if you just think back to, the peak here back in the 80s, can you imagine what it would have been like to be able to tell people at that time, if you just take this pill every day, we will prevent you from getting HIV? What a difference that would have made. It's still the same epidemic. We still have HIV with us this many decades later, and yet we're not realizing the tremendous potential that this product and these products hold. And you can see I've mapped onto here when the first clinical data were published showing that this thing really works. A few years later, almost a decade ago, Health Canada approval, but the line is more or less flat. Not only that, there is tremendous inequity, as we've already been talking about through the last couple of days at this conference, in how these infections are occurring. Our national HIV infection rate is estimated at 6.1 per 100,000, which is already way too high. But when you look in the prairie provinces, Saskatchewan and Manitoba, rates that are more than 3 times that national average, and we know that that is focused in Indigenous people. When you look on the right-hand side, these are again data that have been compiled by PHAC looking at the rollout of PrEP, province by province. And we're using a metric here that's important to understand. It's called the PrEP to need ratio, if you haven't heard of it before. It's calculated by simply taking the number of folks on PrEP in a given jurisdiction for a unit of time and dividing it by the number of new infections that are happening in that same jurisdiction. And when you look at this over time, as you can see, 2018 to 2021, you see that the same 2 provinces have been lagging behind in terms of the PrEP to need ratio since the outset. Notably, if you look in the third set of rows there at PEI, a peer province that started with a low PrEP to need ratio, you see increase in PEI over the last few years that you do not see in the prairies. So what's going on here? There's a lot of complex reasons behind this, and I'd like to explore a little bit of that with you in the next few minutes. Now, I'm going to use data that are focused on some of the work that I've done, which is focused on a particular population, that of sexual minority men primarily. The issues are, of course, very, very different for Indigenous populations, such as the ones on the prairie I've just been highlighting, but I think there are some key commonalities, and at the end I'm going to focus on the key things that I think we can be doing differently in terms of how we think about this that I do think are in common. And before I go any further talking about some of the barriers to broader PrEP rollout, I think we have to understand all of these in the context of the very real structural and systemic barriers that we talk about a lot at CAHR but can never get enough airtime, of discrimination, racism, colonization that underlie a lot of these forces. I think it's worth us remembering that if the cure for HIV, if a perfect infallible vaccine or PrEP product for HIV were a glass of clean drinking water, there are 31 boil water advisories still in effect in Canada right now in 2025 in Indigenous communities. So through the PRIMP project, which is the project I've had the privilege of working on with some colleagues, amazing colleagues in Ontario and BC who work with the same population for PrEP implementation, what we've been thinking about is how we could be doing better at scaling up PrEP implementation in GBM. And to do this, we've been using the concept of a cascade to help organize our thinking. The cascade looks like this. If we imagine that a health system should be able to identify folks who could benefit from PrEP based on something like syphilis infection or a rectal gonorrhea or chlamydia infection, using PEP multiple times, what have you, it's the responsibility of that healthcare system to actively recommend PrEP to that person. If the person accepts the PrEP services, then we can refer them to a PrEP service. They can attend, hopefully, the PrEP appointment, get started on PrEP, and hopefully, if we're going to see population-level impact, we'd like them to be retained on PrEP for some period of time. Here, we've arbitrarily defined that as 6 months. So how are we doing? Well, not great. If you look across these data, which we compiled from a number of different community health centers, public health clinics, sexual health clinics in urban BC and Ontario, you see among all these GBM who had a clear PrEP indication, that along the cascade, we have tremendous drop-off all the way. And this is across almost, 1,300 healthcare encounters in Ontario, almost 3,900 in BC. The largest gap is pretty early on in the cascade. So a lot of folks who do receive the offer or the recommendation for PrEP effectively say thanks but no thanks. And I think we need to understand that step in addition to all the others if we're going to dissect what we need to do better. So we've done that in part by simply asking at the program level, using program data, what's happening at that moment where the person says thanks but no thanks. And you can see that when we've compiled this, some of the time people say, actually, I've got an appointment coming up, which is fantastic. But a lot of the time, the other things are things that we can perhaps pull some levers on, right? A third of the time, people say, you know what, I just don't believe that I'm at risk for HIV, so thanks but no thanks. Sometimes people say, I'm not interested. I'm just not interested, that's it. Sometimes people in a similar vein say they need more time to just think about it, kind of ambivalent answers like that, perhaps legitimate questions or concerns around side effects. And then you'll also notice another category, access issues, right? Medication costs, lack of provincial health coverage. So why don't you just hold some of these ideas in your mind for a few moments, because some of the solutions I'd like to propose and how we think about PrEP could, I think, help to address some of these common concerns. Through the PRIMP study, we've also used another set of data, which is a cross-sectional community-based survey. This has been rolling out on 2 different occasions in Vancouver, Victoria, Ottawa, Hamilton, and Toronto. And Oscar Pica Espinoza from my team a couple of years ago did a study. So these are cross-sectional data in which we, again, looked at different aspects of what was getting in the way of the cascade. And here's just one of the many analyses that we've been able to produce. And we see that among people who say, I was a PrEP user before, but then I stopped, we see that these folks actually give us answers that demonstrate a higher level of PrEP-related stigma than not only current people who are not currently using PrEP, but people who are currently using PrEP. So the way that PrEP-related stigma was defined it can be defined as many. Daniel Grace has done some beautiful work, and others, Carmen Logie, have done beautiful work on understanding stigma and how complex it is and the many meanings that it can have in the context of PrEP and otherwise. Here, it was defined as agreeing with a statement like, I think PrEP users are, quote unquote, promiscuous, a word that we very much dislike. Also disagreeing with the concept that PrEP is a responsible choice. Okay, so PrEP-related stigma is alive and well. We've been demonstrating that in many different contexts, and here's another data source, our Ontario PrEP cohort study, in which we looked at the trajectories of how people were talking about their experiences of stigma over time. This is just an early look at some of the data on about 350 participants. On the graphic on the left-hand side, each thin horizontal line that's stacked up here represents a participant. And what they're doing is telling us at baseline, at 12 months, and at 24 months, to what extent they've experienced PrEP-related stigma. So green is good, no PrEP stigma reported. Yellow is anticipated PrEP stigma reported, and red is enacted stigma being reported. I won't get into the complexities of what people actually said they told us they were experiencing, but you can see that about 30% of the time, people are experiencing these different forms of stigma variously over time. So lots of challenges, people not feeling supported effectively by society in using PrEP, feeling not interested, feeling ambivalent, feeling like there are access challenges. So in the last few minutes, I'd like to propose to you that we need to simply rethink what PrEP is all about. I think the way we thought about it is purely as a clinical intervention. We kind of slapped it onto formularies and said, okay, now it can be prescribed, very passive voice, and then walked away. And that's not the way to think about a public health intervention. If we think about PrEP as a public health intervention, then we're going to think about all these different circles here. So we need to think about what we can do to attract more users. We need to make sure there are enough providers to deliver the PrEP. The drug needs to be available. And we need to do all of this in a way that centers health equity and centers the value of PrEP choice. And I think we're very clearly in the era where that can become a reality. So I'd like to talk through each of those just in a couple of slides in the last few minutes. You can see that we're going to start with PrEP users. And to do this, I want to draw your attention to some work that we've been doing, co-led with my friend and colleague Mark Hall, with a tremendous panel of experts from across Canada in developing guidelines on PrEP and PEP. This is the set of authors that was involved in the earliest iteration, which you can see was back in 2017. There's an update that's coming any day now. It's currently under peer review with a slightly different panel of wonderful experts. And I want to comment on a few things here. First of all, the very fact that this group of wonderful volunteers went ahead and undertook this work is emblematic, I think, of the public health failure of PrEP in this country. We did this to fill a very conspicuous vacuum in the public health space at the time that PrEP had already received regulatory approval. There was tons of evidence out there showing that it worked. It was becoming publicly reimbursed in many settings, and we knew that there were naysayers out there, including within our very field, people who had perhaps some honest skepticism about PrEP. There was a clear need to go out there and say, this is a good thing, this is how to do it responsibly and safely. It was not happening. So we went and said, well, I guess we'll do this, and developed some guidelines. And I want to tell you a little bit about how we've reconceptualized this idea of who the users could be. And I want to really shout out to community members who have spoken to us in consultations and given us feedback over the years about how we perhaps got it wrong a little bit in the first iteration of the guidelines, as well as some Black scholars who called out some concerns around how the initial iteration of the guidelines could have perpetuated some anti-Black and other racism and other forms of discrimination. So we've really rethought this and said, you know what, the impetus to start on PrEP can come about in different ways. Sometimes people are just going to ask for PrEP themselves, and if that happens, we now say it is completely appropriate and reasonable to prescribe PrEP to that person. Okay, the reason for that is that the older way that we had been thinking about it was effectively a form of inappropriate gatekeeping, and it wasn't sensitive to the fact that many people have very real historical and systemic reasons to not be able to fully disclose what the risk behaviors are that may realistically put them at risk for HIV infection. But that's not to say that healthcare providers don't have a role. It is our responsibility to also assess HIV risk actively and do so during routine health visits of all sorts to identify folks who could benefit from PrEP who may not even know about it and certainly may not be asking for it themselves. We've already highlighted how many times people simply do not recognize their own HIV risk, and here is a huge role that healthcare providers can play in rolling out this public health intervention. To assist providers in doing that, we recently completed a systematic review of HIV risk assessment tools. The protocol is on the left, and the publication is forthcoming any day now. If you'd like, you can see a sneak preview of that work. Monica Rudd from my team is going to be presenting that in the oral abstract session this afternoon in the clinical sciences session. And here's a quick summary of some of what we found in that work. There's lots of validated tools out there for GBM for assessing HIV risk, but really not a lot of others for other key populations that would be relevant to Canada. Although there are 6 tools for cisgender women, for example, out there in the literature, all of them come from sub-Saharan Africa, a context that is very, very different from Canada, such that the items in those risk tools are really not applicable, even to African women who may be newcomers to this country. So there's a huge gap, and we have some suggestions in the updated guidelines on how we can think about PrEP eligibility in a new way, hopefully a more enlightened way to bring more people into the fold. But one last thing I really think we have to do if we're going to think about PrEP as a public health intervention is we need to be shouting from the rooftops that this is here and it's a positive, healthy choice. People are internalizing PrEP-related stigma that I think we are perpetuating as a system, unlike some of our peers in other jurisdictions. So if you look at some of this imagery, you'll see celebratory images about what PrEP is all about. You see diverse people represented. They're not all gay white men. Benefiting from PrEP. And if you squint, you still won't be able to see that at the bottom of this little graphic here, the people who created this image, which is a photograph I took standing at a bus shelter in San Francisco some time ago, is the San Francisco Department of Public Health. We need public health to be out there shouting about PrEP so that people don't wonder what it is, know that it's a healthy choice, and actively destigmatize it. I'd like to point out that if you were to ask an average person in Canadian society whether they thought that public health officials in this country thought that it was a good idea to get, say, the COVID vaccine or a measles vaccine or a flu shot every fall, unequivocally people would say, yeah, I know that's like public health supports that. Substitute the word HIV PrEP into there, people will say, what are you talking about? No, isn't that something that's for, sluts? This is a problem and we can fix it. Okay, the next part of the puzzle is of course providers, and the theme here is that we need to be engaging way more providers, way more types of providers in this effort. And I think it really starts with nurses. Nurses are awesome. Nurses are at the front lines and really are the face of PrEP in many successful settings around the world, including here in Canada. And I want to do a shout out to some of our colleagues in Victoria, in particular Patrick O'Byrne's team in Ottawa, and many others who have been publishing and demonstrating the feasibility and the impact of this sort of approach. Patrick has really thought about this task shifting as a form of role optimization. And I love that terminology, really pushing us to encourage all health professionals to work to the very limits of their capabilities in terms of their expertise, in terms of the regulatory framework, and you can see the amazing impacts that it can have. The papers here show that when you offer PrEP to the same person many times, eventually you can actually have some success in the initial skeptics. If you offer PrEP right after PEP, we can get more people engaged, and working with the OHTN, they've been able to demonstrate that with the increased rollout of this PrEP, nurse-led PrEP program in Ottawa, we've actually seen a decrease in HIV diagnoses in this population in Ottawa. Who else? Well, primary care providers are also the very face of the healthcare system across this country. And there is something in the PrEP literature that's been called the purview paradox, where we say, as infectious diseases specialists, we'll say, oh, well, this is a primary care intervention. This lives in primary care. It's primary prevention. But then the primary care providers say, hang on a second, HIV drugs, I don't know about that. That's a specialist's field. It's not in my purview. So everyone thinks it's not in their purview. We have this paradox here, and we think that primary care couldn't or shouldn't be more involved. The data suggests otherwise, of course. If you look at reporting, more than half of providers more than half of PrEP users are getting their PrEP from someone who's qualified in family medicine. Now, I know that's a misleading thing to say because a lot of the time these are folks who are working in a sexual health clinic or a public health clinic, but just have that training. But if you look in the BC data, I was pleasantly surprised to see this recently when I looked at this. 20% of PrEP users in BC are receiving it from someone who is giving PrEP to only 1 to 5 people. Okay, that's not the picture of someone who's working in a busy sexual health clinic delivering PrEP. That is the picture of someone who is just out there in their practice, seeing heart disease, seeing PrEP. And that's what we need to be doing more of. My team a few years ago tried to think about how we could disseminate knowledge about the guidelines, the first iteration of the guidelines, in a patient-empowering way, a patient-initiated continuing medical education program to bring accredited CME to primary care providers. And we hope to do something similar in conjunction with Katie. We're doing some modules on the updated version of the guidelines and using this as a knowledge dissemination strategy. Online PrEP providers are also really, really important and provide an innovative new way that we can delivering healthcare to people. Many of you will, of course, be familiar with Freddie, which is operating now in many provinces across the country, and that's fantastic. There are some glitches, there are some concerns, there are things that Freddie itself is working on optimizing, but if you just look at the numbers, they have really been able to make a difference. I learned from Kaylee Shukolek the other day that they have so far started 27,000 people on PrEP in just the short time that they've been operating, and currently maintain 13,000 on it to this day. They clearly have a role. They're working on expanding and improving their services. They're not available to all. It requires an online connection, but boy, do we need more options for delivering PrEP. And then finally, on the provider front, we're right here in Nova Scotia today, and I want to do a huge shout out to Tasha Ramsey and Debbie Kelly and their team, who have been really innovating and pushing the field forward with pharmacist prescribing of PrEP, demonstrating on the left that it's acceptable to users and community pharmacists, demonstrating in the middle in a forthcoming publication that it's effective and we can overcome some of the key concerns that people have expressed about pharmacy-based PrEP prescribing, and finally on the right-hand side, actually showing policy impacts such that pharmacists in this province can now prescribe PrEP, which is a tremendous success. You can see in the reporting there, though, that cost is still a barrier, and we must not forget this. This is a public health intervention. It's a global public good, as they say, and yet we have not been reimbursing it as such as a system. There are some yellow star, gold star jurisdictions, P's and T's here, that are making PrEP available in a universal access program, and that's to be celebrated, but some of our largest jurisdictions continue to simply slap it onto a publicly funded formulary and expect the rest to run itself. That's not enough. There are co-pays that make it a barrier, and the data tell us repeatedly that this barrier is enough to stop people who could benefit from starting on PrEP. As I said, we also have to be thinking about this in a way that centers health equity. And here are some data from Wale Ajiboye and team members. I think he's going to be presenting this later today as well, demonstrating very real racial disparities in PrEP rollout in this country. You can see here that in this cascade, this is a hypothetical cascade based on cross-sectional data, the number of people who have heard of PrEP is considerably lower in Black compared to white folks, as well as Indigenous compared to white folks. And there are also disparities when we look at receipt of PrEP and maintenance on PrEP on the right-hand side. Although it does look from this graphic as though the Indigenous folks are actually doing better on the right-hand side of that cascade, recognize that the way this particular cascade was built was that these proportions are proportions of the prior step. So because we have inequities at the upstream parts of this cascade, the inequities actually do persist across the whole thing. How are we going to do this? Well, we need data. Winston Husbands told us this on our opening night. Lawrence told us this yesterday morning. We need the data in order to understand how we're doing, but programs are not collecting it and they're not reporting it. So kudos to British Columbia for actually putting out a PrEP report based on the data that they do collect in that public program. They've done some careful work to identify specific indicators that they report out regularly. And if you look at that list here, you'll see that race-related, ethnicity-related data are noticeably absent. How can we know how we're doing if we're not tracking the data? The data are being collected but not reported, and that is a failure. In other places, it's not being reported at all. And finally, I want to just emphasize that we need to think about PrEP in the context of choice. PrEP is no longer one thing. It's many things. It's a pill you can take daily. It's 2-1-1 PrEP. It's a ring. It's an injection. It's an even longer-acting injection. It could be an implant. It's going to be an infusion. It's going to be a long-acting pill, MK8527. It's going to be a one-yearly injection. There are so many things that PrEP is. We have this beautiful menu of choice, of options, and I think Canada is really, really well positioned to lean into this in a way that even some of our peer countries are not. Unfortunately, long-acting injectable CAB has been considered and not funded by peer countries like Australia and the UK, which differs from what's happened here in Canada. We have an opportunity and we must not squander it. If you look at data from other fields such as contraception, we know that choice is important because the more options you offer to a population, the more uptake you get. So this is a seminal study showing you data in which each dot is a country. The x-axis is the number of available contraceptive options in that country, and the y-axis is the proportion of folks who are using some form of contraception. There's this beautiful, clear relationship. Making more options available simply leads to more uptake. And we've seen that in our own field as well. Those of you who have been following the results of the SEARCH study in Uganda and Kenya will know that they've clearly shown in a number of randomized trials that were well conducted that compared to the standard of care, which is kind of what we've done in much of Canada, just throw it out there and let people kind of do it according to normative guidance. If you create an intervention in which you offer people a structured choice, you explain to them PrEP, you explain to them different forms of PrEP, you explain what PEP is, you can achieve tremendous increases in coverage with some kind of biomedical HIV prevention option, 56.4% across these studies. Not only that, when you introduce a brand new, very different modality like long-acting injectable cabotegravir, you see new users introduced. 42% of those starting on CAB-LA were not on any prevention product at baseline. And we can kind of see that in our own data here. Here are just some older cross-sectional data we collected in the context of a discrete choice experiment that we did among GBM undergoing HIV testing in Toronto. And we asked them about their interest in hypothetical PrEP options well before some of these were available. And you can see on the right-hand side that as the number of hypothetical PrEP options be increased, the proportion of people who were going to end up on no product at all based on our inferences went down. Not by a huge amount, but ultimately it really depends on whether the folks who do become engaged in PrEP might be those who we have failed to engage previously, who might be at the highest risk of HIV acquisition. And I think nowhere is this concept more clear than when we circle back to the dapivirine vaginal ring. I showed you earlier data showing that this product is actually not all that efficacious, certainly lower than daily oral TDF, and yet the WHO approved it specifically for women in many sub-Saharan African countries because it represented more choice. And that's been the case now for 4 years. It's being rolled out. This concept of mosaic effectiveness means the more options you have, even if they're less effective than what you've already got, you get more uptake, and that's what we need. So to end, to realize the promise of PrEP in Canada, I think we need to do a lot of things. And ultimately, we need to think about PrEP as a public health intervention. That means a lot of things. It means we need to maximize users by expanding eligibility, ending gatekeeping, and doing a lot more work to create the demand. And I think this really lives with all of us in this room, as well as our public health leaders. We need to decentralize and diversify the range of PrEP providers, and I've shown you some clear data showing how that can be done and is being done across Canada right now. We must have universal access to drugs. Some copays is not good enough. And we have to be tracking what we're doing to ensure health equity. We need the race and ethnicity data, we need gender-based data in order to know how we're doing. And throughout all of this, I hope that we can emphasize choice. PrEP is no longer one thing, it's many things. There's many safe and effective options that mean that there should be a PrEP option that could be well-suited to virtually anyone who could benefit. So with that, I want to thank all of our study participants who've made this work possible, the amazing members of my team, many of whom are here, the members of our tremendous guideline panel, some former trainees whose work I've shared with you today, some colleagues who've commented on some of the slides today, and our funders. And I thank you most of all for your attention today. Thanks. I think the idea is that we have 6 minutes and 32 seconds for questions or comments, if there are any.
Hello. Bonjour. Santiago from Queen's University. Thank you for this marvelous presentation. I have noticed, providing HIV care for a while, that one of the barriers I've encountered, and it makes people say no to PrEP, in my experience, is the commitment to come back every 3 months, have blood work taken, and go to a clinic and many times wait too long to be seen and examined by a doctor. Some clinics, because I've asked around, do it virtually. No, some are better than others and more effective. Some are run by nurses who maybe work faster than us. And but how would you see that? And I don't see any recommendation in the guidance. No, should we see them just once a year and then virtually every 3 months, or how can we optimize that and not treat them as patients because they're actually not sick? No,
Absolutely beautiful points. Totally agree with you. A couple quick responses. So the updated guidelines. First of all, the updated guidelines they are clinical guidelines more than anything. They do comment on implementation somewhat, but their focus is largely clinical. But what you talk about is a really important area that we need to work on more through implementation science research, I think. And one of the recommendations that we do make in the updated document, and we've been speaking a bit about today, is the need to diversify what we think of as a provider. Right? What you've just described is absolutely a bottleneck, but that's why we need nurses working in different sorts of settings. That's why we need pharmacists, who are the most accessible healthcare provider, according to many Canadians. That's why we need online services that could deliver PrEP to people at whatever hour of the day, even across time zones to accommodate people's working hours. There are many ways that we can innovate. I like to point out, the very fact that things like injectables require healthcare providers to do something different now, provide an injection, means that it's going to force us to rethink implementation, and we need to harness that opportunity, that requirement to rethink, to reimagine. That's what we've been doing through our Future of PrEP is Now project with the Community-Based Research Center. And some of the things that we're learning is, pharmacies are an important venue. Perhaps we should be doing more mobile units. There are amazing people who do great work with street-involved populations in our field that can innovate and pave the way here. I think there's a lot of opportunity for implementation science research that would speak to some of your concerns. Over here.
Thank you. Excellent presentation. My name is Ruslan Malut. I'm from UNICEF, and we also face challenges in rolling out PrEP for younger populations, so in countries with low resources. And it brings me the thinking that your presentation, so going back to the times of Dr. Ehrlich, who received the Nobel Prize in 1908, for his concept of magic bullet. So where we can treat pathogens with substance without harming the body. So, and I asked actually ChatGPT, so if Dr. Ehrlich would be alive today, so what he would say to us. And that was a very interesting answer. So it says that PrEP represents the modern embodiment of what I dreamed of, a targeted chemical that protects the body without harming it. In my time, we sought to cure. Today, you prevent infection altogether. This is a triumph of rational drug design and immunological foresight. So I'm just thinking about all the myths which circulated about PrEP today and prevent people from taking it. Is it the time to move it also to the Nobel Prize, candidate? Because this is something which is humanity never discovered before. With this recognition, will help to advance PrEP to the levels where we'll have coverage not 5 or 9%, but really much, much higher as we achieved with children coverage with vaccines.
Yeah, thanks for your comments. I think that's an example of a situation where ChatGPT was not hallucinating. PrEP is tremendous. Is it a silver bullet? Sure. Does someone deserve a Nobel Prize? Sure. Perhaps. That would be nice. But I think we needn't think quite so, I don't know what to call it, maybe almost elitist in a way, that we need someone to get a Nobel Prize. This is something all of us can do. This is something that our local public health units are doing and need to be doing more of. Celebrating it, we need to fund public health a little better in this country in order for them to do that job. But all we need to do is say it's right here. There are many ways to access it. We just need to do it. It's universally available in virtually half the country. It's publicly funded in another half of the country. Yes, we can elevate it to that level, but this is something that all of us should be promoting and talking about in our daily work.
Est-ce que je peux vous faire pratiquer votre français?
Voilà.
Avec mon groupe, on a fait une revue systématique sur les impacts de la gratuité des médicaments antirétroviraux. On a trouvé dans une belle étude américaine où, quand on donnait la PrEP gratuitement versus donner un coût de seulement 10 $ par service, on faisait doubler le nombre de gens qui abandonnaient quand on imposait un frais. Récemment, le gouvernement fédéral a pensé à un programme d'accès des médicaments national, puis ils ont choisi les contraceptifs puis les médicaments pour le diabète. Je me demande si on n'a pas raté une opportunité de véhiculer notre message pour rendre les médicaments antirétroviraux gratuits. Au Canada, on rend les antituberculeux gratuits pour l'ensemble, puis on a des succès mirobolants en termes de contrôle de la tuberculose, comparativement en moyenne internationale. J'ai l'impression qu'il y a une opportunité politique pour rendre les antirétroviraux gratuits de façon nationale.
Absolument. Je suis complètement d'accord avec ce que ça fait. Ça dit, merci beaucoup pour la suggestion. Je pense que c'est exactement l'esprit de mon diapo là sur le fait qu'on a des programmes de remboursement pour la PrEP qui sont universels, mais seulement dans quelques provinces de ce pays. Ça devrait être complètement gratuit et disponible à tout le monde qui peut y bénéficier. Il y inclut les personnes, les personnes sont les assurances, comme les immigrants, les réfugiés qui sont au Canada. C'est vraiment un bon de santé publique qu'il faut faire plus disponible. We need to make antiretrovirals and PrEP completely universally available. Okay, I think we've got time for one last one here.
Hi, I'm Cord Dalton. I'm a pharmacist from Saskatchewan. And my question, we're kind of trying to make a strategy in Saskatchewan around PrEP, and the future of injectable PrEP is a big topic. One of the big concerns is rolling out cabotegravir injectable and loss to follow-up and resistance. Do you guys have any strategy or like plans or advice about tackling that?
Let's chat offline, maybe. Again, an area ripe for implementation science research. We know that persistence is a huge problem and is a key metric that needs to be tracked in PrEP programs of all sorts, be it injectable, oral, or otherwise. But I think, once again, there's lots of opportunity for innovation here. There's great community-led models, diverse types of providers who are going out there doing active outreach rather than the very passive system that was alluded to before, expecting people to walk into our clinics between 9 and 5 every day to get their services. Yeah, we need to be doing more. We need to make all of it available because, again, different services are going to work for different people. And yeah, we can't wait to see what you come up with in Saskatchewan. We'll work with you. Thank you.
Great. Thanks.
So thanks so much, Darrell, for what I knew was going to be an incredibly informative presentation, sharing of information, but also for that call to action, because I think we all support the fact that we have a role to play as healthcare providers, pushing our public health agencies and bodies to go forward, and continuing to work with our communities to help get the word out and improve access to PrEP. So please join me in thanking Darrell once again. And on behalf of CAHR, we have a little token of appreciation. Thank you.